Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
For sharing your Saturday morning with us. It's been wonderful. We're going to move on now. Thank you so much. I really appreciate it. Hopefully, I'll come and visit Penn very soon. I see that you have some adverts up out there. Anyway, it will take me some time. All right, no problem. Thank you. We have another Dr. Eva in the house. She's Dr. Eva Boldridge. Dr. Eva, are you there?
Yes, I'm here.
All right. I'm just going to go out. We're going to go ahead all the way from Houston, Texas. Dr. Eva Boldridge received a dental degree from the Medical University of South Carolina in Charleston, South Carolina. She had a prosthodontist training at the University of Alabama in Birmingham, followed by a fellowship in maxillofacial prosthodontics at the MD Anderson Cancer Center in Houston, Texas. Dr. Boldridge has worked in private practice for over 15 years in the greater Houston area and has served as assistant clinical faculty at the UT Health, University of Texas Health School of Dentistry in the GPR and AAGD program. Dr. Boldridge's field of interest includes digital dentistry, 3D printing, full mouth implant restorative, and digital dentures. Dr. Boldridge is currently serving a term on the American College of Prosthodontics Board of Directors as Region 4 Membership Director. Welcome. Welcome to our dental webinar series, Dr. Boldridge. Please go ahead and take it away.
Okay, give me just a minute. Okay, you see my screen?
Yes, yes.
Okay, let me move this. Okay, let's see if I can reduce this down. Okay, so I love the beginning of the first lecture because, believe it or not, I still get pearls from when I hear other people lecture. So a lot of what was said before really goes into what I do in my private practice. And what I'm going to lecture about today is actually when you're in private practice, how to build a team when you're in private practice. Now, the teams depend on what you're doing in private practice. If you are placing your implants and restoring them, or if you're sending them out to someone else and then you're restoring them. I come from a different standpoint, so my viewpoint will be basically coming from a restorative doctor. Most of my practice is referral based, so a lot of my cases are sent to me by surgeons. I do not place implants. I was actually one of the last graduating classes that we were actually given the option. Either we wanted to place or didn't. And everyone calls me a little bit of a diva. I was like, nah, I don't want to do that. I just want to place implants. I mean, I just want to do the restorative. So that's kind of what I do in my private practice. But there are a lot of people, especially all the new prosthodontists coming out, they're placing their own implants as well. It really just means whatever you're doing in private practice, build something up that's successful for you. So let's get started. Full disclosure, I'm not a paid spokesperson for any dental implant company or product. All the opinions are mine, unless I'm directly quoting somebody else. A little bit about me. Like I said before, I'm a maxillofacial prosthodontist and regular prosthodontist practicing for over 15 years here in Houston. I used to be part-time faculty in the AGD GPR program, and I'm a member in the ADA, TDA, Greater Houston Minority Dental Society. But when you get down to it, I'm a soccer mom, swim team mom, theater mom, and also a part-time. But my daughter is turning 16 in a few months, so she's going to become the new Uber. the biggest change in my life was I was appointed by Dr. Baba, the president of the ACP last year, to be on the board of directors for my region, Region 4. And that was a very, it was an honor. It was a very humbling experience. And I've got to learn quite a bit about being active at the executive level in my specialty. And I've been very humbled by just the whole experience. You can see in the top picture, that was us last year when we got together for our meeting. And at the bottom, you can see that we had to do everything virtual because of Corona. So this has been an interesting year serving on the board. When we're, excuse me, let me go back. What I'm going to basically go over is responsibilities and what you need to think about as a restorative doctor or as a surgeon. And then I'm going to show some cases about, you know, how we work together to make things work. And sometimes when you don't work together, how things come out. And then at the end, just a few pearls, just things for you to think about how you can make your practice the best it can be and keep challenging yourself to do better. When everyone talks about implant dentistry, I make a really funny joke because everyone talks about it being like fuzzy bunnies and unicorns. You know, that's what implant dentistry is. You get an implant and kumbaya. But, you know, a lot of other stuff can happen. When I first got into my pros residency, I heard a lot of residents talking about, you know, these failures, you know, I don't have any failures. That just happens to those other doctors. Or, you know, I've never had an implant failure. I heard this one, even a monkey can place an implant. And that kind of always gave me the cringe because even as a resident, you start to see all these things coming in, and almost all these pictures are cases of patients that I've had as a resident or in private practice, or I've had a referring doctor send me some pictures about cases. So as you can see, not everything turns out great. And yeah, I still have more. Every time I do a lecture, I add more on. About things that happen. Most common thing I'm getting recently are broken implant screws, where I have to back out screws. And that's the middle picture right here, as well as the one above it. The real reality is that if you treat enough patients, you are going to have some complications and failures. Even if you don't see them, they're still there, because the success rate is usually around 92 to 96%. And it really does depend on a lot of factors that was stated earlier. What is a lot that's going on? Well, I think failures are two aspects: the aesthetics failure and then the implant failures itself. With the aesthetics failures, you could have a lack of keratinized tissue around these implants, so it makes hygiene really bad or really challenging for the patient. They start to get chronic inflammation. You can also get chronic inflammation from old cement retained crowns. Another thing to consider is when the implant was not placed correctly or the right size. And a lot of times that was due to people, surgeons freehanding it and maybe just not as experienced. No one comes into implant dentistry just being perfect. You're going to have things that aren't ideal. The biggest thing is, are you going to do something about it? Are you going to learn and grow from it? What I see also are, you know, the implant failures. You see some that are early failures, and then there are slow delayed failures. Early implant failure, a lot of it you will have with patients who are possibly uncontrolled diabetics. I still have some with smoking, because especially with vaping, I've had one recently. You're getting poor wound healing. You also got to consider occlusion. If you are loading a single implant crown and you're not taking into effect occlusion, you could have some problems. Other things that can affect osseointegration is just there was not a lot of stability of bone around the implant when it was placed. Was it loaded too early? And a lot of what we're seeing in one of my cases that you're going to see is that we're wondering if these anti-anxiety medications are having some effect on the osseointegration of implants. Late implant failure can be related to periodontal disease, especially if you still have teeth in the arch. You can get inoculation from other sites. You could be overloading the implants, or in this case that you see right here, this patient had a whole bunch of implants placed and they were never loaded. And as you can see, he started to lose bone around it. Like I said earlier, you can also have drug interactions and occlusion. That can always be a killer for you. In my years of private practice, I've come to the point that implants are just a part of everyday dentistry. Everyone has to be taught in the area of implant dentistry. Whereas before, when I was in my residency, they were just thinking about introducing it in the undergraduate. Now it has to be, because everyone is using it and you're getting patients from all over. You've got to have knowledge. They're a great tool to utilize, but you've got to make sure that you know what you're doing. A lot of these patients, I'm seeing this mixed dentition where you have single tooth implant and a tooth fails, and then you got another implant. You've got to start thinking about occlusion on these patients. What I've also seen is, since I've left, is that we've completely gone back to screw retained for single units as a way to minimize flash from cement and long-term failure because of flash and cement not being able to clean away. I'm also seeing a trend of, there was a time for about a good 8-9 years that a lot of people were going to more generic brands and not using the more common implant companies. And I'm seeing that trend starting to go back away. I think it was because some failures, and also implant companies don't usually give you, if you're not using their parts, they won't always refund you if something fails. I've also seen that patients are way more educated. There are YouTube videos for everything, and if you are not trained, and if you're getting your CE to know what you're supposed to know, these patients will come in and they will know more than you. So you've got to know this stuff. And of course, intraoral scanning and 3D printing, every 6 months, something new is coming out. Even with the locators, you know, we've got the scanning copings for locators now, so that when you're scanning intraorally, you can just put the coping bodies on the implants and scan intraorally. Am I doing that yet? No, but I'm hopefully going towards that route. So, how do you avoid having this happen to you? This is probably the most important screen, and it seems very simple, but it's what I think a lot of people don't realize. You have to build a team, and the team consists of the restorative doctor and their whole team. You can see my team on the screen. It's changed since Corona. The surgeons and their team. A lot of surgeons that I work with have implant coordinators, and even though I have the surgeons on speed dial, if I need specific information, I usually contact that coordinator to get like the easy information, like what implant was placed, diameter, stuff like that. In my office, I did have someone, they didn't have the title of implant coordinator, but they knew everything that I was doing. So it's a lot easier with communication if you have people in place that know what's going on. The biggest thing is making sure that as a restorative doctor, I have to plan with my surgeons what we're doing. Usually I have to do a conference, or I go to their office, and we will go over the 3D imaging to kind of debate what they need versus what I need. And a lot of times you have to really check your egos. I've been very fortunate. Almost all the surgeons I work with are very willing to hear what your viewpoint is and what you need as a foundation to build on top of. most surgeons that I've worked with don't want to have to think about the restorative aspect. They want to be told, where do I place it? How much reduction do I need? And they can take it from there. And that's kind of how I've built my team with the surgeons that I work with. Make sure that you're supporting one another. When something, the patient, I sometimes have patients that will say, I'm not sure about what the doctor is saying. I make sure I reach out to the doctor and say, hey, let's make sure we're on the same page with this, because as a unified front, you work better. For your team, make sure that you are educating them about all the different options that are out there, because as soon as you leave the room, the patient will always turn to your assistant and say, what do you think about this? So if your team is trained in knowing about the different treatment modalities, they can be your backup as well. And the most important is making sure that you educate the patient about their treatment, their pros and cons. I sometimes have patients who go, Doc, whatever you say is best, I'll do it. Of course, I love hearing that, but I want to make sure they understand the time commitment, the financial commitment that goes into this. Sometimes patients just want to, go to sleep, wake up with teeth. And in a lot of my cases, that doesn't always happen. Again, outcome expectations versus reality, making sure you do your homework, and we'll talk a little bit more about that, so that you can educate your patients in confidence. A lot of times patients think we're like magicians, oh, we can just create everything. Well, we do a part, but we have to make sure that they understand that there's time and there are things that we have to do to make that smile the way they want it in the end. As a restorative doctor, you really have to be kind of like the quarterback. That's kind of how I view it. In American football, the quarterback is the one who's calling all the plays, but that quarterback doesn't do everything. You have to make sure that you are there from the beginning so that at the end, everything works smoothly. That means making sure that you read the CBCT imaging, you do your diagnostic whack, you talk to your lab, which is very important, making sure that you have the restorative space and the space between implants to make sure you can have everything fit and you're not compromising adjacent teeth or the implants. Planning what kind of surgical guide you want and how you want to distribute those forces. My diagnostic wax-ups, these are some of the older pictures. I still sometimes use old denture teeth. I still measure the diameter and making sure that I have space for where the implants are going to be, and making sure I have enough space between the implant and the tooth, and between two implants to not compromise the interdentals and the inter-implant space. You also have to give an idea of what kind of bone reduction that you will need. You can't just say, take off a little bit. I usually have a bone reduction guide, or I will say exactly, no, I usually put it on the guide. I usually always do guides. There's very rarely that I just say take off a little bit. I usually have a guide that shows the surgeon exactly how much bone to take down. It takes the guesswork out for the surgeon and for you. Know your surgeon. I work with quite a few surgeons in the city, and each one of them is different. You've got to know what systems that they use. And most surgeons that I work with have 2 or 3 implant systems that they use that work best in their hands. They also have a preference of what kind of surgical guides they like to use. Now, in some situations, I want a fully guided, but in other situations, like in the mandibular arch, I can give them a little bit more freedom. I have found that when it comes to my all-on-4 or all-on-X cases, most of the surgeons I work with do not like fully guided. And in most of my cases, I prefer that they don't have fully guided, because in those patients, they usually have really poor bone, and sometimes you don't have stability where you thought you would. You've got to plan for these cases, and that means talking with the surgeon, hearing what they're concerned about, and trying to make accommodations and plan for that. Also, like I said before, implant coordinators, a lot of surgeons have implant coordinators, working with them so that you make sure all the parts have been ordered and you know what's going to happen the day of surgery. Another very important part is your implant rep. Their numbers are on my speed dial as well, and they know if they're getting a call from me, I'm picking their brain. And I've been very fortunate. I've had some wonderful, wonderful help from the reps that I have worked with. They are such an essential part of the implant team. They can give you information about whether or not there's angled channeled abutments, different angulations. What labs do they think that a certain case would probably work better for you? I have my favorite labs, but in certain cases, and one in particular that I'll show, I didn't want to use my lab. I wanted to use a lab specific with the implant company, and you'll see the reason why. Most missed mistake by even myself sometimes is talking with your lab. As you can see right here, an implant was placed in lower anterior, and I already knew this, but I will talk about this one later. But you need to consider the restorative options. You have to talk about the mesh if you're doing a full arch, the abutment. How is it going to be angled? Is it going to be screw retained? Is it going to be cement retained? All these things are very important. And if you're not planning ahead of time, you're going to get an email or a phone call from your lab saying, "Doc, we need to talk about something." So if a case looks like it's going to be a lot, give your lab a heads up. Let them tell you what they need to make sure everything works smoothly. As a restorative doctor, this is really, really important, especially since we're such a global society at this point. Especially in Houston, you've got to make sure you have some sort of documentation system for the implants and parts that are used for patients. I have patients that travel all over the world. Sometimes they're going home to other countries, and you've got to make sure they know what they have in their mouth, so that if they're going back home or they're traveling or they're moving, they have all the information to help another restorative doctor treat them. We are very mobile, like I said before. Patients are living longer. I really liked this that Nobel has started to do. They gave an implant card for the implant, and you can copy that and give that on a sheet to the patient, so they keep it with their very important documents. I, of course, keep everything in my clinical notes, but if you even make a form that the patient can take with them and have in their possession, it helps so much more. The reason why is you don't want to be the restorative doctor that's going to have to go call offices or go to whatimplantisthat.com or start checking radiographs and everything else. Those options are there, but I really encourage you to be proactive and put some sort of system implemented in your office when you are in practice, so that the patient as well as you know what implants are there. Implant hardware and selection. As a restorative doctor, what system are you using and why? Again, angled screw channels, very important for me in the anterior. What abutments do the implant systems use? The diameter and the length. In certain areas, the shorter implants have higher failure rates. That's not true with all implant systems. Manufacturer versus generic. Again, that's kind of changed. I'm not seeing as many generic implant options here in the US. There is one company that does it, but I'm seeing more and more people move away from that. And the final, restorative. we've completely gone back to screw retain, like I said before, but that doesn't mean that I haven't had to do cement retained, and I'll show you one of those cases. And then your full arch restorative. There are so many different options that you just heard in the other lecture. Which one is best for your patient? Again, this is more about the cement retained. Making sure that you cement outside of the mouth, and then that's only if you got a good path of draw. Surgeons. Now, again, I'm not a surgeon, but this is kind of what I have to go over with the surgeon, and I hear them talking about they have to consider. So yes, I attend almost 90% of my patients' implant surgeries. It's very rare that I don't. The only exceptions are the patients who have to be in the hospital, and I don't have hospital privileges at all the hospitals here. All the recommendations I have come from working with the surgeons. They're not very specific, but I will be as eloquent as I can to try to state it. Surgeons are looking at the bone quality. Of course, in the maxillary arch, your bone is softer versus in the mandibular arch. I always tell patients, you know, the lower arch, we usually don't have as much problems. You can put 2 implants down there and you're good. The length of the implant really depends on how much bone loss has already been there. The surface quality of the implants, the existing bone amount, the site that we are placing these implants, especially when you're having to consider sinus slits, which I have to have in a lot of my patients, and what kind of grafting material or what kind of grafting are you going to have to do. With the surgeons, I really recommend that you talk with your surgeons about what kind of guide works best for them. And this also puts the onus on the surgeon to make sure that their surgical approach is cohesive with the surgical guide that you're using. Some surgeons like to do just 1-stage implant surgery. Another surgeon I work with, he likes to just clean everything out, graft it, and then do a stage 2. The reason why I say the surgeons really have to think about what their surgical approach is I've had a patient where we were going to a fully guided surgery, and the surgeon started to do a flap that completely made the surgical guide inadequate. And it's still a challenging case that I haven't finished yet. If you're going to use you have to make sure that your surgical approach is cohesive with the guide that you're using so that you can still use it. I know you need keratinized tissue around the implants, but as a surgeon, you've got to make sure that whatever guide you're using can be used the way it was intended. Let me go back. With the surgical team, make sure that the CBCT is sent, a copy of that is sent to the restorative doctor. You also need to coordinate with the restorative doctor if they want to come to the surgery. Every office knows that I work with that you got to call Dr. Boldridge to schedule to make sure she can come to the surgery. Making sure that you have the supplies you need, extra implants just in case the bone is not the way it's supposed to be, adapters for the fully guided surgical guides. And if you need an implant rep to be there for any additional help, and they usually have some backups just in case. If you let them know what's going on, it's better than you're in the middle of the surgery and you need a part and your team is calling the implant rep saying, hey, do you have something available? Yes, that's happened before. You never know, but it's always best if you're having a big case, especially a full arch, and you're still in, pretty new, or even if it's a case where you don't know how it's going to go, make sure you let your rep know in advance. And here's a picture of quite a few of the surgical teams that I work with. I'm pretty notorious that whenever I come visit, I usually bring some pastries because I always know my cases are a little bit more challenging. So most of their faces are smiling because, I fed them. Now we're going to talk about clinical cases. And what I'm going to show is just different cases and how we've had to work together to make them work smoothly, Some of them are what happens when you don't get involved from the beginning and you don't have the teamwork that you'd really want, and how you kind of work around it. So the first case is a double arch implant restorative, which was kind of like a conus denture. And this patient came to me from the surgeon. The patient had rampant decay, periodontal disease, poor oral hygiene, suffered from very low self-esteem. She really didn't want me to take her pictures too, but I always document for every case what the patient looks like when they first come in. It's very, very important. And I was coordinating with the surgeon for a full mouth treatment. And as you can see, a lot of decay, periodontal disease. There was a lot going on in this case. What was very good, though, is that this patient, she had tons of bone in the mandibular arch, which was very, very good. And we had just enough bone in the maxilla. So like I said before, every surgeon is different. This surgeon was, his approach is always take everything out, clean it out, graft it, and then we'll go in for a second stage. So my diagnostic wax up was actually the mediate upper and lower denture. And like I said, we did full mouth extractions and then we grafted. We went back in with imaging and we planned. I went to his office and we planned with a service provider that makes fully guided surgical guides, and we planned to do 4 implants in the maxilla. We also planned to do 4 implants in the mandible, but the surgeon felt more comfortable having just a duplicate denture with a trough, giving him a little bit more freedom to place the implants. And we, of course, called the surgeon, the implant rep, making sure we have all the parts and the pieces ready, and planning just in case. The second stage surgery went, very well. It was fully guided, and it was pretty smooth. The implants went in fine. The biggest thing for the lower arch is making sure that all the implants are as parallel as possible, even though with conus you have CAD/CAM milled abutments that can accommodate for any implants being off, but we found that this was actually really good. We went in, and of course, we do just like we would do for any case, open tray, impressions. We did a verification jig, wax try-in, abutment try-in with the jigs, and do the delivery. So you can see the abutments try-in with the abutments. We picked them up extraorally. And the patient actually opted to do the lower arch first, wait 6 months, and then we went in to do the maxilla. The only problem is I changed laboratories. And in the end, I ended up having a case where the mandibular arch did not match the maxillary arch because the labs used different acrylics. The other catch is like we said before, with the conus, you have to really make sure that your phalanges are shorter. My patient was very happy with her teeth, so happy that she went camping, and she went camping for like a week, and she really didn't clean like she was supposed to, and she had food debris that caught underneath the denture, and it was locked in for 2.5 weeks. I show you this picture of this forcep because we had to use that to get the conus denture off. So I've learned that you have to make sure that your phalanges on the conus are a lot shorter so that you can get it out. And it also have to lecture the patient about making sure they clean. This is the patient before and after, and outside of the denture being locked in, she's been very happy. Ironically, she lost over 100 pounds. And by the time she left us, she was walking in her cute little outfits, and she was a completely different person. So it was very interesting to see the change in the patient over this period. What I've learned from here, here's a few things. Trust your surgeon. They know what works best for them. And surgeons, make sure you know the surgical approach that works best with you. For the conus, you can really only have them on 4.0s or larger implants. Uh, Always do a verification jig. Those are very important. And like I said before, cut the phalanges short. Otherwise, you will have a very unfun time trying to take that denture out. Now, full disclosure, I told the patient as I was delivering it that that was the one side effect. So when it happened, she knew it was happening. And like I said before, use the same lab. You can see on the top, the maxilla is a little bit different from the mandible. And I had to do extrinsic, external staining to make sure that the upper arch matched the lower arch. I forgot to put a picture of that in there, but that was not fun. Full arch fixed. This was a case that was referred to me by a general dentist. The general dentist wanted to do the mandibular fix, but did not want to do the hybrid on the maxilla. So they wanted me to just do the maxilla. The problem is that the mandibular arch, as you can see, was not ideal. And I had to ask the restorative, the general dentist to make new temps for me, because I couldn't make something to that. So the patient couldn't even start their surgery until they had increased the vertical and changed the arch width, especially in the anterior. I worked with the surgeon. We had a little powwow and we planned 6 implants and we were ready to go. And with this case, I did something different. When you do a hybrid denture, you need approximately at least 15 millimeters of clearance for restorative space. So what I did is I measured from the incisal edge to 15 millimeters, and then I made holes all the way around the immediate denture. And that way the surgeon could actually go through and make holes all the way around and make an even cut. So it was almost like a reduction guide. I did this because I didn't know if the implants could be loaded or not. So one way of trying something different was saying, well, if for whatever reason we can't load the implants, we can still use the upper denture and we don't have to cut it. Because usually I cut my immediate denture to the 50 millimeter, so the surgeon knows exactly where they're supposed to cut. But with this one, I wasn't sure, so I was covering my behind. As you can see here, the bone, you can see the little bit of indentations, and the surgeon was able to take down that bone and do very good reduction. And he thought that was kind of cool. And we loaded all 6 implants on this case, and we had the rep there, which was very good because we needed some extra parts. And in this situation, the implants were placed, and when it came to testing for the loading, the surgeon didn't feel comfortable with 2 of the implants placed, so we had to go back, and he took out those implants and moved them. So making sure that you have backup if things happen is really important. Her status right now is, well, please excuse the picture, that was my adjusted wax try-in. She liked her teeth and she disappeared for a while, big surprise. We loaded all 6, but we're getting ready to do her final restorative. And the lower arch is finalized, and you can see the crowns on the lower arch are a lot better aesthetically, and lip support, and she's really excited. So we haven't finished it. She started traveling more, and then Corona happened. So now we're at that stage, but everything seems to be working very smoothly. So we're really excited about this case. The lessons I learned with this case, you need to have that mandibular arch in a more ideal setting before you even started. And that meant having the general dentist and their lab make new temporaries. And I had to make sure that it matched with the occlusal scheme that I needed on the top. in the maxilla. The way I was trained is I usually have the mandibular arch set the standard for the occlusion. So I needed something more stable and more towards the final before I could go forward. We worked with two guides. One was the denture itself, and also I had a hollowed out maxilla duplicate denture just to tell the surgeon where to not go too buccally. We again have the rep at the surgery because we needed extra parts. The non-ideal, these are a few ones where I get cases sent to me and I had no input until the implant has been placed. So this is more of what you don't want to happen, but if it does, this is kind of what you need to consider. And I talk to the surgeons about, this is what we need to think about the next time you come up with something like this so that we don't have to do this again. This one was referred to me from the general dentist. They said they did not feel comfortable restoring this implant. And at first I was like, well, it's just a single implant, it doesn't look like it's that big of a deal, until I looked and the patient opened up and the implant was placed way too palatally. And I was like, ugh, okay. And in this one, we did a screw retained, of course, and I had to educate the patient on what kind of restorative that we're doing. And I had to educate her on making sure that she cleans underneath that little flap in the front. So she actually is really happy, and she knows that she needs to clean, and we have her on a pros recall. But in this situation, it would have been preferential for the surgeon to really graft that area, wait, and then place an implant in a more ideal position. This is what the final looked like when it was in. And although the shade looks like it really sticks out, it really didn't. So I'll have to say that was my camera. The patient was very happy. She was tickled. She knew she had to do a little bit more work, but she was very happy. So I would almost say it's not really an aesthetic failure. Well, it kind of is. But functionally, my concern is that the implant forces are going down the wrong area of the implant. Here's another case where the patient was missing number 25 for a really long time, and he was wearing a flipper. And those lower anteriors and the upper laterals are usually the ones that you see the biggest oops with, because you just don't have much space. And the surgeon placed the implant and there was no surgical guide used. I think there was grafting, but I'm not sure. But I was just sent it when it looked like this. And the surgeon said, I want it screw retained. And I said, So initially I have my 3D scanner and I tried to put a scan body in there, but you know what? The lab said, no, we can't see. And I ended up having to do just a conventional impression. I could barely get the impression post in. So I knew what was happening. When the lab called me, they said, look, doc, there's just no way that we can do a screw retain because of the implant system doesn't give an altered chamber access so that you can have everything go towards the lingual. You can only go through the facial. So in this situation, I had to call the surgeon and say, yeah, we can't do this. It's going to have to be cement retained. And the surgeon said, you know what? I understand. We'll go forward. So it was a cement retained, and they did a little bit of opaquing, so it didn't show through. And the patient was really happy. He didn't have to do his flipper. I told him about, making sure he cleans around it. It was a very tight space. So it was an aesthetic success. But ideally, if we wanted screw retained, it wasn't the most ideal. In this situation, I would have to say for the surgeons, when you have such a small space, you really need to have a surgical guide, because you could be limiting the restorative material on either side of the implant. Avoid freehand placement in these compromised area. And if you are going to use an implant system and you're not really sure, make sure you have a system that has an ankle channel access for the anterior aesthetic zone. You can talk to the restorative doctor before placing the implant, because we always like to see it before. And you also have to consider, again, restorative space, not just the bone around the implant. What's the profile of the access hole coming out? This was a case that, ironically, again, I had no input on, and I was actually, I think, the 5th doctor on the case. This patient was a 18 or 19-year-old female. She had congenitally missing teeth, and she was first put in ortho, and then there was a prosthodontist and a periodontist involved, and they tried to place implants, and she had multiple failures, so many that you can see how much bone loss happened in the lower anterior. So there was an orthodontist, a periodontist, a prosthodontist, then an oral surgeon, and then I became the final prosthodontist. I have to say, I know the prosthodontist that was on this case, and he's a mentor of mine. I gave him a call and I said, hey, what's going on with this case? He was very wonderful. He said, look, this is what I've done. And he actually made it very, very easy for me coming in. I felt kind of guilty because most of the work prosthetically was done excellent. So I just had to walk in and fine tune some things. Implants were placed in the area of 512, there were screw retained temps on 512, 20, and 29. And then there were implants that were not uncovered, which were at 7, 10, 22, 25, and 27. And this is what you can see in the maxilla. You can see the screw retained temporaries that are premolars, one that was molar. I mean, everything looked really beautiful. The lower anterior was of a concern to me because of all the bone loss. So I had to talk to the patient and her mother about realistically what could be done in that area. And I also talked to the laboratory as well. I got the heads up from the laboratory and the rep before even touching the case. I actually called the rep in, and we had to go through the whole litany of all the implants, making sure I had the implant parts ready, because the plan was to do at uncovery is to make a fixed in the lower anterior area. And I made a little, I guess, acrylic partial in that lower area. That was my diagnostic wax up. I processed it, and the plan was to pick it up at the time of surgery. When we went in for the uncovery for the lower anterior, this was challenge. The patient was very sensitive. She had had multiple implant failures. The tissue and the bone, everything set her on fire. Unfortunately, the uncovery was done at the end of the day, and the surgeon was tired. It was a tough day. There was bony overgrowth over the implants, which is kind of good, except for if you're trying to put abutments in there, you have to keep calling the surgeon back to uncover it. And because the surgeon didn't have the right parts for me to be able to, for healing abutments while I was taking everything out and jumping it, we couldn't deliver it. But I learned a lot that day. I learned that the patient was very, very sensitive. You had to really have them at the beginning of the day, and you had to really explain everything that you did and take things very slowly. So my assistant actually came with me, and even though we stayed till 7 o'clock that night, that next time we saw them on, everything went pretty smoothly. The other thing that was kind of a challenge is that 2 of the implants were really close together, and that the implants were placed very close to the defect ridge. and I would probably have made the defect a little bit more square shaped, but I just had to deal with what I had. So when I delivered the temps, it actually went pretty simple because I'd made sure the surgeon had removed all of the bone around the implants. We just uncovered and placed it, made sure the contacts were good, and we made temps for the 7 and 10 as well, screw retained temporaries, and let the patient just sit in that for about a month. We wanted the tissue to kind of be contoured so that it would already be shaped. So when we put the fixed in and the final, everything went smooth. And that's when I put it in, and she had never had anything fixed in the lower in so long. It was very interesting to see her reaction. And like I said, we did screw retain temporary so that when we did the final impression, the tissue was already formed. And you can see the nice sulcus that we had there. And the delivery was pretty seamless for everything. All the screw retained temporaries, I just had to give screw retained final crowns. 7 and 10, we opted to not do pink porcelain because we know that 8 and 9 have a poor long-term prognosis because she's lost so much bone. She has an anterior open bite, so we really didn't have to worry about that. We did use a laboratory that was recommended for the implant company that we used, and everything just went in so beautiful. The patient, she was just so tickled to be able to lick her teeth and not have any kind of partials or flippers. She was moving to Europe, though, to go to college. So we actually had an extra set of models made for her with a list of all of her implants. And she keeps this in a box. And I've told her she has to keep this forever so that if she moves, go to school, if she has to see a restorative doctor where she is, she has all the information she needs. What I learned from this one is that you really did need all the disciplines working together to get the space ideal. You needed the surgeons for the implants and then the prosthodontist to make sure that the tissue was formed, you had the right space. What was sad though in this case is that the patient had implants placed when she was way too young, around 10 or 12 years old, and I would definitely not recommend that. So she lost way more bone than she probably should have. You should really keep track of your implant parts because especially if you have a patient who has 8 implants, it can get kind of confusing. I would have preferred a different implant placement in the lower anterior and a different shape of that defect in the lower anterior, but you know, that's kind of what we were dealt with. And when you're having uncoveries with your surgeons, you really have to make sure that you ask them to remove all the bone all around the implant. Otherwise, you won't be able to get your abutments seated. And unless you're willing to go in there, you have to send them back. And with everything changing now, we probably could have done a different option for the mandibular anterior area. I had a metal substructure with processed teeth on top. We probably could have done something different, like with Trinia. There's new materials coming out, but I wanted to keep it old school on her and be conservative because she was so young, and I wanted to use things that would be tried and true. The last case I have is one that was a case that's still going on, a patient who's had multiple implant failures. This patient had extensive dental history. She had a full mouth rehab before. She had huge anxiety problems. Just if I touched her, she jumped. You could see all of the pathology that was going on in her mouth. It smelled bad. She lost her vertical dimension, active periodontal disease. And on top of it all, she had a really funny jaw movement where she would protrude her lower jaw. Like my more elderly patients, she had this really strange tick, which would prove to be the bane to my existence. Excuse the pictures, they weren't the best quality. An upper and lower arch. And I put that one in there, even though it's fuzzy, just to show you how much, I mean, even when we were taking impressions, she was jumping. I planned this with the surgeon. The surgeon was confident that we could do a double on X, which is kind of like a hybrid on the upper, on the lower arch. We didn't have much area in the maxilla, but the surgeon felt comfortable in doing it. I had an upper and lower denture, so I'm covered. No matter what, the patient's going to leave with teeth. But at the time of extractions, the patient bled so much, we couldn't get anything placed. We just had to close it up and let her heal. It was just bleeding everywhere. So she wore an upper and lower denture. For the second surgery, I gave the surgeon a hollowed out duplicate denture for the mandibular arch. And the surgeon, she was able to place 6 implants in the mandible and 4 in the maxilla. But we did not load anything in the maxilla, and the surgeon only wanted to load 4 implants in the mandibular arch. So I went in that day and I jumped the lower denture and made it a hybrid, and she was able to leave with fixed teeth that day. The challenges that came with this is that for some reason, when I did this, we had an impingement on the patient's tongue. And that, on top with the parafunction, was the bane of my existence. She had 3 breaks. She had a hard time keeping hygiene in the lower left area. In addition to that, yes, her dog took her upper denture, and I had to remake a denture in 1 day. And like I said before, she fractured her lower interim 3 times, and I had to remake it 1 time. So I did 2 repairs, and then I just remade it. We thought everything was great and finalized. I started to get ready to take final impressions, and that the day of final impression, she started to feel a little discomfort in the maxilla. And this is what happened. And that's the site you never want to see. We ended up taking that out. And as you can see, there was no bone, nothing on that implant. And then 6 months later, another one in the maxilla failed as well. So where are we with her right now? We actually are getting her ready to do a hybrid, to finish the hybrid on the lower. She disappeared for a while as well, decided to travel and have a good time. And then we had Corona. So I have everything ready for her to do her wax try-in. I just have to get her to come back. That is one of the challenges I have with patients. You get them looking and they kind of disappear for a while. We did have a concern about, she's taking a lot of anti-anxiety medications, and we're starting to see information in the literature about implant failures associated with her with anti-anxiety medications. We have started to prep the patient to understand that we may not be able to do any implants in the maxilla. We have thought about doing zygomas, but to do zygomas, you would ideally want to have at least 2 in the anterior maxilla to help, and we may not have that. And we have to think about quality of life, and the patient also think about finances, because this has not been a cheap experience. The lessons I've learned with this case, the parafunctional activity was really, really hard. She has a tongue movement, and that could also be the reason why we're having problems with the implants in the maxilla, but we're not sure. The extensive medications could be a possible side effect. The patient's anxiety, I think, actually got better. At this point, we can touch her and she just kind of laughs. She's actually improved greatly. We have to prepare patients. When things don't look good, we kind of have to give them realistic expectations. And she's been pretty good in all of this. Other patients, I would think, would kind of have a breakdown, but she kind of goes, another implant, okay. I always make sure that I contact the surgeon and the implant coordinator when anything goes on. And if I come up with any ideas of things that we can do, we've tried it. We've even tried Botox on this patient, but it hasn't helped. We have to also just try to be flexible with treatment. There was a time that we thought we were going to do locator FTX on the patient instead of doing a hybrid. But we've gone back to say, you know what, let's do the hybrid. We think we're okay in the lower arch. The last bit are just some pearls, little bits of helpful information that I've come across. And the biggest key here with implant teams is that you've got to communicate. If you don't communicate, things fall apart. Make sure you're using your support team, which is your lab and your implant reps. Sometimes you have to think out of the box, and doing that means you have to reach out to other people. Don't isolate yourself. Find some people who can be mentors you can throw ideas off of. One thing with implant dentistry is you just have to keep learning. If you have to do study clubs, do whatever you need to do to keep growing. And if something just seems out of your realm, know when to refer. I've had to refer some cases too. So no one can do everything. And sometimes you just can't see it. So it's better for yourself, your sanity, and for the patient. And most importantly, when you're in a team, support each other. Look out for each other. Give them a call. Hey, I think you need to look at this. All these things help to have camaraderie. This is very important for me. Make sure your front desk team, they appreciate the fact that you need to have x-rays and the referral form sent ahead of when the patient gets there. Occlusion, occlusion, occlusion. Whenever you're working with a case, occlusion can either destroy or make things great. So making sure occlusion is looked at. This one is the most interesting one. Be open to your treatment ideas. Do not be afraid to openly talk to the specialist. I have gotten really good at treatment ideas from my restorative doctors, and I hope to return the favor. Brainstorm the problems and do not become too set on your solution either way. Treatment plans are fluid, interactive, and a good place to learn something. And try to treatment plan what the profession can offer, just not what's in your toolbox. And I think I'm done. So if you want to follow me on Facebook or Instagram, Houston Pros, and I also have one that's Denture Diva. I'd just like to thank everyone for the opportunity to come in and speak to you today. And I guess I'm done.
All right, thank you so much. I'm applauding you here. This is really, really wonderful. Today has been a very, very awesome day. This presentation are really super. We have them recorded, so they're going to be posted to our YouTube site. I'll send the link out, and if you go there, find it and subscribe to it. You can listen to it. We're going to send out, Dr. Eva. I'm going to request for you to send me some 6 questions with answer options. I was not able to put the ones you sent because I wanted you to be part of what the content of your presentation. So I'm going to get
6
down.
questions.
I don't know, because just looking at your presentation, I could see so many. I mean, the questions are just shooting at me in terms of what can go wrong, what you have to look out for, stuff like that. But things that go back to the presentation and watch, and I'll be able to answer on just. So thank you. Dr. Anandyosi, are you there? I know we have a couple of questions. I'm going to pick anyone, either of you, to answer any of the questions we have here. Dr. Anandyosi, are you there?
Yes, you cannot see me?
Okay, it's okay. It's all right. I wanted to, can you see the questions on the chat?
On the chat. I see the one on Q&A.
Okay, you want to answer that one first, then I will pick on some others.
Yeah. The question is, how is the resorbed ridge an indication for implant retain overdenture? That's a very good question. So when we have resorbed ridge, we don't have enough support area to support a complete denture. So actually, this is when we want to add a retentive feature to support the prosthesis. So as long as we take a CBCT and we measure the bone volume and we have enough to be able to place a reasonably sized implant, then resorbed ridges is a good indication for implant. The location of the implant might be different depending on where we have enough bone to place the implant. But without it, the prosthesis would be so unstable. With it, it's our only chance that we have. Of course, if the bone, let's say on the mandible, it's less than 8 millimeters on the mandible, then yes, at this point, the resorption is too much to place an implant. But for anything else, especially on the mandible, it's pretty rare to not be able to place implants.
Okay. Dr. Boldridge, a question for you here. So what would you suggest for occlusion training for implant supported prosthesis?
Okay, what was the question again? I'm writing my questions too.
So what would you suggest for occlusion training?
Actually, I wish more people would have more occlusion training for implants, especially for mixed dentition. With the way I was trained, for single implants, you really don't want the implants to be in occlusion when the patient taps, taps, taps. You need to make sure when they squeeze hard, they hit just lightly. Now, if you start having patients who have implants here, 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 and here, that starts to become harder and harder. So I cringe when I start to see patients who had a tooth that was lost, they throw in an implant, and then you start losing more and more, and you're really relying on the natural teeth to really give you proprioception. That's not really giving you an answer, because I really haven't seen a lot of lectures that talk about mixed dentition occlusion. Now, when you're doing a full arch, it's a little bit different. And especially if you're doing like a double hybrid, that's a little bit different. Even when they're in their interims, you really don't have them in occlusion past their premolars. And patients are like, I can't really chew. And I said, yeah, that's supposed to be, you're not supposed to chew. You're supposed to look good, but you're not supposed to chew. So occlusion, whew, that's a whole huge lecture.
I know on its own. That's thank you. Yeah. Anyway, we would. So what I'm going to do, I'm going to send your questions as a survey. So because I think we need to go back both questions. So we all get a second chance to answer Dr. Anandioti's questions again. I'm going to send it out as a survey. So I would like for you to go through the materials on YouTube, listen to it, because sometimes it's a lot of information. You need to take some notes and get another opportunity to answer. So I'll send you both questions, and once you get it, once you send your answers to the questions, I'm going to send you an attendance certificate. So just, there's no pass or fail, just the efforts that you're going to answer all the questions, and whatever. To tell you, the answers are going to be there once you get once you click submit, so you'll be able to tell whether you got it wrong or right, and just learn from the experience. Just in between here, I'm going to give a shout out to Christine Wakesa. Christine is from Kenya. She's a dental student from Kenya. We need all your dental students from Kenya in here. I need to connect us with dental faculty from Kenya. There's also someone from Uganda. There's a couple people from Ethiopia and a lot of people from Nigeria. If I didn't mention your country and you're right there, I want you to type it in the chat. I'm going to move on to this two more questions here before I let you go this Saturday evening in Nigeria and afternoon in the United States. It says here, how would you deal? This is Dr. Ebrashi. Dr. Ebrashi is going to be with us this Friday. He's a prosthodontist from Portland, Oregon. He said, how do you deal with a patient with a protrusive habits with a failed upper implants?
That's a good question. So she actually went through a phase where, we tried to do Botox to kind of minimize things, but it didn't really work. When I remade the lower interim hybrid and kind of gave her more tongue room, she didn't do it as much. But we are actually going to be looking at her medication list and possibly speaking to some of her medical providers to see whether or not she still needs to be on all the medications that she had before, because she doesn't even know why she's on some of them. In the maxilla, I think my gut is telling me that she just may have to be in a denture. She is very good about wearing her occlusal guard. And when she's around the house, it's like a running joke. She takes her upper teeth out. And that was also a concern to me because one, she did that once and the dog took the denture. And number two, when she takes it out, sometimes she still has the habit of going like this. So I don't know. The answer is I don't know. You'll have to see another lecture of mine to see how it turns out.
All right. Okay. There's another question here. Can you see all the questions? Dr. Anandusi, can you let me check? For some reason, I can't scroll all the way. I know we have two more questions for you from the top. One wanted you to describe, splinted and unsplinted, just to give a little overview again.
Yes, for tooth retained, for unsplinted, we can have no attachments, no copings, nothing. You just retain the teeth, dome shape, make them shorter so you have enough room for your denture. If you use a coping for unsplinted, it can just be milled or cast and to just cover the tooth, no attachment on it. You can also put an attachment on top of it. It can either be cast or milled, and it will have a retentive feature that will actually lock into place when the denture is inside. And then similarly, when you're doing implants, you can have unsplinted, you can have prefabricated abutments like the locators that we talked about, or ball attachments that you're just directly screw inside the implant and then they lock in the denture. Or you can have CAD/CAM abutments fabricated, customized for the implants that can correct angulations, improve parallelism of the implants, calculate restorative space, has a lot of benefits. And then for both options, tooth or implant retain over denture, a bar would just connect, splint the implants together. It can be either cast or milled nowadays mostly. And then the mill part would be inside the denture and it would just go around the bar. And as we said, the problem with the splinted is not only the additional cost, but the restorative space that has many biologic, maintenance, phonetics, and aesthetics limitations.
Okay. One more question here. It says, can you state the difference between implant retained and implant supported?
Yes, that's a very good question. And we have that discussion very frequently, both in our school, but I think at the college too, to try to define. The most recent that we had, when you're talking about implant retained, means that portion of the retention comes from the implant and the remaining retention comes from the soft tissue. And when you're thinking about mandibular implant retained over denture, you only have 2 implants, and then probably 90% of the remaining denture is retained on soft tissue. So it's equally important to be able to have good retention on the implants and impress the soft tissue well so that you have good support and retention from there. Implant supported is when most of the support and retention comes from the implant. So when you're using perhaps 4 implants on the mandible, or you have a larger number of implants, so most of the retention of the prosthesis is on the implants and not so much from soft tissue.
All right. Thank you. Thank you so much. I really appreciate your giving us your Saturday today. It's been very, very educative, very, very stimulating lectures we've had, and I know that many people are going to be requesting for the videos. Hopefully, I should be able to upload them shortly. Thank you so much. Any last words from both of you?
I just want to thank you and all of the attendees for the opportunity and the attention. It's been a real pleasure to virtually meet all of you, and I'm looking forward to more in the future.
Right.
I'd like to echo that. Thank you so much for having me here. And it's always great to see my girl, two Evas back-to-back lecturing.
I think we should establish that more frequently.
Just to
Yeah,
let
we
you
should
know,
do that.
just to let you know that both clinicians today are very active on Instagram, so you go check them out. They have wonderful posts all the time, and we're looking forward to having Dr. Abrashi on Friday and Dr. Press on Saturday. We have a little change to the schedule on the 27th, but this is what it looks like right now. But this weekend is going to be packed. We have on Sunday, we have Friday, Saturday, Sunday, and it's all going to be recorded. And this is going to transition into an online course. If you want to be a part of it, we're going to put up a sign-up sheet very soon next month in July. We are going to have a laboratory component, because talking about implants virtually sometimes is you need to have something in your hands. And there's going to be a laboratory component to this course that will be piloted at the University of Benin. Professor Sede, Professor Sede, are you on there? Are you on the? I thought I saw you earlier. Just let me call. I'm just going to call on Professor Sede. He's a professor who has given us an opportunity to use to work with his university, where we're going to be piloting a laboratory component of this course for undergrad and residents. Anyway, thank you so much and have a wonderful Saturday. I'll see you all on Friday. Bye-bye.
Thank you again. See you later.
Okay, bye-bye.
Bye, so good to see you both.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator